So here we are for part 2 on autism. I'll try to fumble around a little bit less than I did on the last one. And what we're going to really do now is just focus primarily on what differentiates a typically developing brain from an autistic brain. And a natural question to wonder is, are there any sort of quote unquote global signatures that really differentiate the autistic brain and the typically developing brain? Like, is there an absence of some brain region or an enlargement of some brain region or less activity, more connectivity? And are there any sort of global signatures where you could just look at a person's brain and be like, oh, this person probably has autism because look at their brain, they're missing or have a different version of this one particular brain area? That would be nice. It could be a very useful clinical and diagnostic tool. Unfortunately, something like that doesn't exist. So there's not really any global signatures. There's a few hints in the literature, but even those hints are fairly poorly understood. So for example, here's one from the textbook. So if you look at a relationship between how large the total cerebral volume is in cubic millimeters, correlated with how old the person is at their MRI scan. So this isn't fMRI, this is just an anatomical MRI scan. You get a whole bit of data that looks like this, okay? Now, this is a lot of data, these are a lot of points, so let me try to walk you through it. So the first thing to notice is as you go further on the right, the brain volume goes up, because this makes sense as you get older. You know, when you're 1 year old versus when you're now 6 years old, there's a pretty significant difference in how big your brain is, okay? But then what there also are these red lines and these blue lines. And here is this now solid line here in red and this solid line here in blue, okay? And the solid red line is showing the size of the cerebral volume in autistic individuals over time versus in neurotypical developing individuals over time. And so one thing you can notice is that on average, the autistic brain seems like they are larger when in these early years than they are in control populations, okay? It gives some impression that perhaps one of the things that either is a cause or an effect of autism is increased cerebral volume. Now, you might be wondering, why would a bigger brain potentially be playing a role in autism? Sometimes, I believe they even reference this in the reading, they talk about almost like the Goldilocks idea, which is like not too big, not too small, just right. If you have smaller cerebral volume, there's a whole array of different sort of neurodevelopmental disorders you can have. If some of you might remember several years ago, for example, when the Zika virus was a thing that people were very concerned about, one of the biggest effects that Zika virus has is dramatically decreases cerebral volume in children or newborn children. Whereas it seems as if for autists, it might be overshooting it a little bit. Now, even though this might be the case, you really can't use this as a diagnostic criterion, because you can just look and see, sure, if each one of these little like combinations of dots is a single person, sometimes an autistic person and a control person are really similar to one another. You can just see that the blue and the red are really interdigitated with one another. So even though maybe on average, the red ones are a bit higher, it's certainly not the case that you could scan someone's brain, look at their total cerebral volume, and diagnose them on autism alone like that. That certainly really wouldn't work. And then again, why is it the case that we see an effect like this? There's not a great explanation over and above much more about this sort of Goldilocks idea. So if that's looking at total brain volume, a natural thing to look at, and this is what we'll spend the rest of the time looking at, are really about functional differences and perceptual differences. So not just in the size of the brain, but differences between autistic individuals and typically control developing individuals, differences in how those brains act. So not just how they're organized anatomically, but how they respond functionally. And so one of the earliest things that people actually tried with autistic individuals, which was based on the paper you all read, is basing on this question of, do autistic individuals have an FFA? And FFA is a very important visual sort of region. Face perception, face processing is something that autists struggle with. We talked about looking at facial expressions. In a little bit, we'll talk about the ways in which we saw with those little infants, we saw how the infant who later developed autism did not make eye contact as much, whereas the infant who was a typical infant would make eye contact a lot more. So there's a lot of reasons to think that autists are interacting with a face differently, so maybe they're going to have similar different FFAs. So the first thing that they did is they scanned a bunch of typical healthy individuals, and you can see some of the normal regions. So FG, you can think of FG as being the FFA because FG stands for the fusiform gyrus, and the FFA stands for the fusiform face area. You also see a little bit of activation in this region over here called the STS, which refers to the superior temporal sulcus, which we'll actually talk about a little bit. And so the question is, what does this look like in people with autism? And overall, what they found was something that looks like this. That while you might get some activation for other types of stimuli, it doesn't seem as if you see face selectivity in the autistic visual system. You don't see it in the amygdala, the fusiform gyrus, or the STS, this region here. So this is a very exciting idea for a lot of people. Like, okay, we now have like a pretty strong, clear, simple thing that we can maybe tie to autism. And in reality, I say simple because you can localize a person's face regions in 5 to 8 minutes in a scanner. It's a pretty simple type of experiment. It's nothing super complicated. Honestly, by this day and age in 2020, it's really actually like fMRI 101 is localizing a face region. And so a lot of people wanted to follow this up, as is often the case in science. When there's an exciting result, people want to follow it up. People want to first replicate it. And they were able to do that, okay? So over here, you can see some control individuals. There's the FFA. You see a little bit of FFA there. And then in autism, there's no FFA, okay? So people got even more excited because they're like, well, if it's being replicated, that must mean it's true, right? Actually, unfortunately, the answer really is no. That since the paper you read came along, since these replications of the paper you read came along, someone realized that all of these studies were making a very crucial mistake in the way that they would run the study, analyze their data. A question that I would have been interested to hear what you all think is, well, what do you think they did wrong? Okay, so the question is basically, people took some autists and they took some control individuals, put them back in the scanner, showed them a bunch of different faces, objects, scenes, whatever, and they actually were like, oh, if we tweak this, if we make sure to account for that, like the effects that you found disappear. There's a lot of different guesses that people had, but I've already actually kind of hinted at it. The issue is that it comes down to the way that autistics and control people look at face, because typically developing people will look more in the eye region, whereas people who have autism, they won't look in the eyes as much. They'll look a lot more towards the mouth, the chin, sometimes at the shoulders and the neck. So what these experimenters did is they put autistic individuals in the scanner and they made sure that they kept their eyes up here. And so basically, if their eyes ever moved away, they would either throw out the data or they would kind of reinforce them, like, please try to, keep your eyes up here. So just kind of force them to keep their eyes up here, which is not what they naturally do. What they naturally do is avoid eye contact. And it actually turns out if you can just get autistic individuals to look up at the eye region and the typical place where typically developing individuals will look, you actually can see that there is high functioning and highly active FFAs in autism. And so this just was another instance of, okay, there was this possibility. Oh, I just noticed this. These are two FFAs, and for this person, that's their STS. This big thing right here, that's the superior temporal sulcus. This was one of these other cases, again, where there was a hope for a candidate signature of autism versus control populations in the brain, but that didn't really pan out so well. But certain other regions have panned out and have been replicated and have been shown to be pretty tried and true in the autistic brain. So speaking of this region, the superior temporal sulcus, we haven't really talked about this, but this actually is another region that's pretty heavily involved in social cognition and social perception. So what I want you to do is I want you to look at these dots, and what you'll notice is that in a second, when these dots over here start moving, you can kind of already see how it's like kind of like a tiny person. Like that's maybe this is like their left shoulder, their right shoulder, that's their arm, another arm, their like hips, their legs. And so what you can do is you can show people moving dots that move kind of like this, where you can see it's like a person walking, compared to when you scramble those dots. And it's the same motion trajectories, but in this particular case, since they're scrambled, it doesn't make a coherent pattern of a person that looks like they're moving. And so what you can do is you can alter how much or how little you scramble to make this kind of a hard task. And so what you can do is you can go in to people who have autism and people who are a control population, and you can ask them how good are they at differentiating between if it's a person having biological movement, motion, walking, running, jumping, versus more scrambled motion. And what you see is that there's a difference that looks like this, where people who do not have autism, they are better at this task than people who do have autism. I know we haven't ever talked about what D prime is. D prime is just a way that you can quantify how sensitive people are at this task. So in this case, higher up means they're getting it right more often. So basically, people who don't have autism are generally just more accurate at saying if it's a coherent bodily motion versus a scrambled dots compared to autistics. And it actually turns out that if you then look in the superior temporal sulcus, you find that that particular part of the brain is generally more active in people who are control subjects than people who have some form of autism. So it actually seems as if maybe part of the reason that they're not as good at differentiating between biological and scrambled motion is because the region that is involved in processing biological motion, the STS, is not firing as much as it is in control populations relative to autistics. Now, again, this is all about function. This is not about the size of the STS, the gray matter thickness, or anything like that. It's just about how active this region really is. The superior temporal sulcus is often also thought to play another role in social perception, specifically with things about attention and understanding not just how a person's moving, but how a person's intending to move, how they're attending to the world out there. And so, for example, in typically developing individuals, what you can do is you can have these situations where a person on the screen is either looking at a kind of, an outlier, a little checkered box. And so in this case, their attention and your attention would be congruent. Or you can see what happens when a person on the screen is kind of directing their attention down there. So it's incongruent. And what you see in typically developing individuals is that when it is incongruent, the STS fires more than when it's congruent. It's almost like, oh, that's odd, that's interesting. They're not looking in the same way that where I wanted to naturally look. I need to kind of figure out what's going on. Why don't they have the same attentional priorities that I do? Since there's this incongruency, the STS is going to work a little bit more. You can differentiate congruent and incongruent trials just from looking at the activation of this region over time. Here, meanwhile, is what it looks like in autism. So for example, this is an example where your attention might naturally go here, but this person's attending over down here. You can see that the autistic brain doesn't really seem to process these differences in the same way. It doesn't seem as if this particular region, again, the STS, the superior temporal sulcus, is able to differentiate between when there are these congruent or incongruent violations of attention of another person. And this is very closely related to this idea that people have relating to autism that's referred to as the broken mirror theory, which is basically this idea that autistics in general can't pick up on social cues successfully. So in addition to struggling to recognize another person's facial expression, in addition to struggling to recognize where a person is looking, they also can't necessarily pick up on those social cues. So for example, to return to the idea of facial expressions and the emotions, what you can do is you can ask people with autism, I'm going to show you a face, mimic their facial expression. So if you looked at me and I was smiling, they would smile. If you looked at me and I was frowning, you would want them to frown. If they looked at me and I was surprised, you'd want them to be surprised. And what you actually find is that in certain parts of the brain, and this specifically in the frontal lobe, parts that are somewhat involved in social cognition, you find that in control individuals, this activation will be higher than it is in autistic individuals. So not only will autistic individuals struggle to mimic the social or the facial expressions of other people, some of the parts of the brain that are involved in social cognition are not going to be as active. So in the same way that the STS wasn't as active for biological versus scrambled motion, you see now that these frontal regions aren't as active when between control individuals and autistic individuals. So now, whenever though you're thinking about social cognition, of course, hopefully by this point in the course, you've learned enough by now to one thing that should really spring to mind is when you think about social cognition, you should think about the RTPJ. And so like I said in the first lecture, this is now we're going to talk about a little bit. And so in this most famous study that I'll tell you about, rather than using false belief stories, like, Tommy, I don't need to go through a whole false belief story. Actually, I don't know. You all know what false belief stories are. But remember from the social cognition day, we talked about false belief stories and false photograph stories. What they actually wanted to do is make different types of theory of mind tasks, because sometimes you actually get participants and patients who are of such severe autism that maybe they won't really be able to read. So what they came up with are these little pictorial false belief tasks. They're not actually even really false belief tasks. They're just kind of more simpler theory of mind tasks, excuse me. So in this situation here, what goes on is you see like this sort of progression of a story. Guy drills a hole in the wall. Guy like hangs up a nail in that wall. Guy goes to the easel, grabs this painting, and then you see 3 options. And what you would have to do is say which of these 3 options comes next in the story. And so in this particular case, the answer would be C, because he drills the hole, he puts in the nail, he grabs the painting, he puts the painting on the wall. It's not that he starts painting then, it's not that he replaces the painting with something else. So this is a situation where there's some theory of mind, because you have to infer what are this guy's goals, what are his intentions, what is he trying to do. Whereas here, you also have another story of things happening. But in this case here, there's no person, there's no mind to take into account. So you'd see this panel, then this panel, then this panel. If I were to ask you to say what happens in the third one, you're probably going to say it's this one. So you can understand these sort of causal and effect relationships, but there's no mind involved. There's no intention to the wine glass in the same way that there is the intention here. And similar to the same way you see reduced activation in these frontal regions or in the STS, you also see reduced activation in RTPJ and autism. So, we can still see an RTPJ for sure. That's what this is back here, but it's smaller and it's less active than it is for typically developing individuals. So some of you could be thinking to yourself like, well, sure, we've talked about RTPJ a lot with social cognition, but there's more to theory of mind than the RTPJ. There's other regions. There's the precuneus, there's the medial prefrontal cortex. So a natural question people have wondered is, well, let's not just think about how active or the size or the presence of the RTPJ. Let's think about how it talks to or how well it's connected to other regions. And so you remember a while back, we talked about this idea of functional connectivity, that 2 regions that are very functionally connected will rise and fall together. They'll fire at the same time and they'll rest at the same time. Whereas regions that are not functionally connected, there's really no correlation to how they're rising and fall. And so what you can do is you can take healthy individuals and you can see about all these functional correlations and this functional connectivity between these different regions. And what you can see is that they're just lower in the autistic brain, that there's just not as much kind of coherent, congruent firing of these different brain regions across the autistic brain relative to the control brain. And this is thought to be true for the autistic brain in general, but it's thought to also be particularly true for the social domains of the autistic brain. And then actually even going further back into our day on social cognition, we talked about, I'll just play this, these little scenarios where you're not doing a false belief task, you're not doing anything with false photograph tasks, but what you can see is that there's a little narrative here, there's a little story. You remember that this guy's kind of the bully, this guy's trying to help the little circle. And what you can do is actually look in the brains of typically developing individuals and autistics while they're watching videos like this. It actually turns out that our brains and autistic brains and typically developing brains are brains that are doing stuff really different than one another in a lot of different regions. So like we already talked about, specifically we'll talk about the right STS, again, the superior temporal sulcus, the medial prefrontal cortex, which was another big part of the social mind that we talked about when we talked about social cognition, and even the extrastriate cortex. This is like where visual regions are. And so it turns out that if you just look at STS, frontal regions, and visual regions, you can look at how active these regions are in control populations and autistics. And what you find is something kind of like this, that in the STS, it's much more active in controls than in autistics. In the prefrontal cortex, it's much more active in controls than autistics. Now, what's going to happen in just visual regions, LO, V1, basic sort of visual regions early on in the occipital lobe? It's actually not really much of a difference at all. So it seems as if even though there are these similar visual responses, there are fairly different social responses in the autistic brain. So people have really started to focus on what differentiates the social brain for autistics versus the social brain for control populations. Now, like I said, there's lots of these differences between the autistic brain and the healthy brain. And so even though there are these differences, though, specifically with regards to social perception and social knowledge, there's many other things that we just don't really have time to go into. Sorry that there's a T missing, that we just don't have time to go into about more basic level circuits, more basic level neurotransmitters. And so the reason I'm bringing the fact up that there are these other things is that it could be very tempting, okay? It's very tempting to maybe think that what I'm trying to say is, oh, the signature between the autistic brain and the typically developing brain are these social regions. Maybe you could diagnose people that way. Again, it doesn't really work very well, okay? You might think that if you'll notice like there's a difference in a person's RTPJ, you could diagnose them just from that. Again, I really want to caution you against that because again, let's go back to that slide from the beginning about cerebral volume as a function of age. If I was to say like, hey, I have a person and they're right here, are they autistic or not? You really wouldn't be able to say. You could say on average, there's this subtle difference. On average, people with autism have larger cerebral volume. But look at this person up here in blue. Very large brain, but they don't have autism. Their brain is much larger than some of these red people down here who do have autism. So even though these might be sort of global trends and global signatures and things on average, it's really not the case that people are anywhere in a position that they're even really, to be honest, that close to being able to classify an individual person as having autism just from their brain scans alone. Sometimes it can complement behavioral or clinical measures, but it's really not the type of thing that people are able to diagnose it just from these brain scans alone. Instead, what people are hoping is that by understanding the neural mechanisms behind the autistic brain, they can start to get a more coherent picture of the disorder such that they could eventually, hopefully, develop treatments. Okay, so the very last thing I'm going to say, and we can say this very quickly, actually, unfortunately, is about this definition, or this, not definition, this issue about autism treatments and treatment options. Because sadly, there is really no cure or medicine for autism. There's really only two kind of things that people are able to do to try to aid and help someone who has autism. One is therapy to help them develop their social skills, their communication skills, or sometimes their occupational or physical capabilities. And the other is medicine. And now, though, the medicines, though, are not designed to treat autism itself, they're really more to treat some of the underlying secondary sort of issues that accompany autism. So sorry, it's not that they're there to treat the underlying issue of autism per se, but people who have autism might have increased anxiety, they might have higher rates of depression because they have these social and communication deficits. So the medicine that you're getting them is not to treat the autism, it's to treat some of the secondary symptoms such as depression, anxiety, and so on and so forth. If people, for example, are very sensitive to sensory stimuli, feel somewhat overwhelmed by social situations that they can't really understand, they could get very anxious. So you maybe try to give them medicine to deal with their anxiety. And if you can lower their anxiety levels, maybe they feel more comfortable in a social setting. Maybe they feel more comfortable in a classroom setting. Maybe they feel more comfortable going to see a movie. And so that can kind of aid in their treatment, even though you're not treating the underlying issue of autism itself. Okay, so why don't we actually just stop there? That's been about 60 minutes total. And then the next one that we will do is going to be on neurological disorders broadly. Pretty much the rest of the course actually is going to be about neurological disorders from schizophrenia to trauma to Alzheimer's and so on and so forth. When I say trauma, I mean post-traumatic stress, sorry. And so stay tuned for our next lecture, which will be starting to go into certain aspects of neurological disorders. All right, see you all soon.